intercostal nerve. So intercostal nerve, they are from T1 to T12, and actually they are the spinal nerves. As we know, the spinal cord is attached with 31 pairs of the spinal nerve. Out of these 31, 12 are dedicated to the thorax, that is called the intercostal nerve, and they run in the intercostal groove along with the intercostal vein and intercostal artery. And so they run in the intercostal groove. Intercostal groove lies in the lower border of the inner surface of every typical rib, and it is accompanied by the intercostal vein, the intercostal arteries, and lowermost is the intercostal nerve. And as they are the branches of the spinal cord, so they are the motor component as well as the sensory component of the spinal nerve. As you know, from the ventral ramus where arises the ventral horn, is the motor root arises, and the sensory root is from the comes to the posterior horn, and both unite to form what is called the spinal nerve. So this spinal nerve is continued as the intercostal nerve, and along with this motor nerve, we know there comes the preganglionic sympathetic fibers also, which comes from the lateral horn. And there lies the sympathetic chain, thoracic part. And every sympathetic chain is attached with a sympathetic ganglion. So these preganglionic sympathetic fibers, they relay in the ganglion. And from here, the post-ganglionic sympathetic fibers, they accompany the intercostal nerve. So this branch which goes from the motor nerve of the spinal nerve into the sympathetic ganglion is called the gray ramus communicans. And when they go, the postganglionic fibers again into the nerve, this is called the white ramus communicans. So this is how a typical intercostal nerve runs in the costal groove with the vein in the upper position, intercostal vein, then intercostal artery, and the intercostal nerve in the lower. So this is, they are in the vein relationship. Vein, V-A-N. So this is how all the intercostal nerves from T1 to T12, they are the spinal nerves run into the ribs. Then the branches. The branches of the typical nerve, they are the, one is called the posterior ramus, or branch. This is cutaneous branch. Then comes the lateral cutaneous branch. Then anterior cutaneous branch. Then there is a ganglionic branches, or also called the communicating branches. Then the motor branches. It also has got a collateral branch. So this is how we describe the intercostal nerve under these branches. So we will take one by one. First is the posterior ramus of the spinal nerve or the posterior cutaneous branch. So this posterior cutaneous nerve is the posterior ramus of the intercostal or the spinal nerve. As we know, the posterior root is the root of the every spinal nerve is a sensory root, and it is sensory root ganglion. So it is going into the spinal cord, and both the motor root, which is anterior, and the sensory root both unite to form a spinal nerve. It comes out of the intervertebral foramen. So from this spinal nerve, thoracic spinal nerve, from T1 to T12, a branch goes posteriorly, and this is called the posterior ramus of the, or dorsal ramus of the thoracic spinal nerve, and rest of the ramus comes anteriorly. It is called the ventral ramus or ventral root of the intercostal nerve. The dorsal root goes posteriorly and it divides into a medial branch and a lateral branch, and it supplies the skin over the back of the thorax, because it is supplies the skin, so it is sensory and posterior in position. Then comes the lateral cutaneous branch. Lateral cutaneous branch, as we know, it runs into the, it gives a branch in the lateral part, or in the mid-axillary line. This branch divides into a posterior branch which communicates with the lateral branch of the dorsal ramus, and an anterior branch which goes anteriorly into the thorax in the intercostal space. And this branch, as its name is cutaneous, so it supplies it, it reaches the skin, covering the thoracic wall. So lateral cutaneous branch supplies the skin. With the posterior and the anterior branch. So it has got the two branches, posterior and one is anterior. The dorsal branch has got a medial and a lateral branch. And the postganglionic sympathetic fibers, they accompany the lateral cutaneous branch and they reach the skin. And as we know, in the dermis of the skin, these sympathetic fibers, they will supply the erector pili muscle. As the erector pili muscle only supplied by the sympathetic, all the hair roots, hairs on the skin, they are supplied by the sympathetic fibers, postganglionic sympathetic fibers. They reach via these cutaneous branches of the lateral cutaneous. Then the intercostal nerve now reaches anteriorly. And the anteriorly, the anterior cutaneous branch, so it is the termination of the intercostal nerve. Here the intercostal nerve pierces the costal cartilages and comes under the skin on the anterior aspect of the thorax and divided into a lateral branch and a medial branch, and supply the skin over the sternum. So this is the sternum, this is the costal cartilage, this is the rib. So the anterior-cutaneous branch also divided into a medial and a lateral branch. We supply the skin over the front of the sternum. That is the termination of the intercostal nerve. And this nerve also accompanied by the sympathetic fibers like lateral branch, which reaches the erector pili muscles. Plus the sympathetic fibers, they also, as they run in the costal groove, the sympathetic postganglionic fibers, they also supply the tunica media of the intercostal vein and artery, as they run parallel with them. Then comes the ganglionic or the communicating branches of the intercostal nerve. So ganglionic branches, they are two. One is the gray ramus communicans, which is proximal, and the distal one is called the white ramus communicans. So they are the ganglionic branches. So every intercostal nerve is attached to the sympathetic ganglion. So if there are 12 intercostal nerves, so they are the 12 sympathetic ganglion also. And they are very near to the exit point of the intervertebral foramen of the intercostal nerve or the thoracic spinal nerve. So they are also called communicating because they communicate the intercostal nerve with the sympathetic ganglion. Then comes the last but not the least, the motor branches of the intercostal nerve. So the motor, as the name suggests, the motor branches will they supply the intercostal muscle. That is the external intercostal, internal and intimi. All they are the muscles in the intercostal spaces. So they are supplied by the motor root or the motor fibers or the motor branch of the intercostal nerve. And this motor branch also gives a collateral branch. And this collateral branch runs parallel with the main branch of the intercostal nerve. As the main branch gives the muscular branches to the muscles, the external and the internal intercostal muscles. So these branches, they also accompany the sympathetic fibers with them. And these sympathetic fibers, they will supply the blood vessels supplying the muscles. But this collateral branch, it doesn't have the sympathetic fibers. And this collateral branch also supplies, it also gives the motor branches to the muscles or the intercostal muscle. So they are banded. So this is the collateral branch. So collateral branch, they are also accompanied by the collateral vessels. And they supply the tunica media of the accompanying vessels also. Then these branches, they also supply the pleura, the parietal pleura, which is lining the inner surface of the intercostal or the ribs. Plus, the intercostal nerve also supplies the periosteum of the rib. So the motor branches, they supply the parietal pleura, they supply the periosteum of the rib, and they supply the intercostal muscle. The branches which supply the periosteum and the parietal dura, they do not have the sensory fibers. They only have got the motor fibers with them. The sensory fibers, they are with the main branch. The collateral branch, it doesn't have got the sensory fibers which supply the dura, parietal dura, and they also supply the what is called periosteum of the ribs. So they are not having sympathetic fibers or the sensory fibers, only motor fibers. The collateral branch carries, we supply the muscles and the parietal dura and the periosteum. So this is how we describe the 5 branches of the intercostal nerve. Now comes the applied anatomy. In the applied anatomy of the intercostal nerve, the first and foremost important thing about the intercostal nerve is the intercostal neuralgia. So intercostal neuralgia is the condition in which there is a pain along the distribution of the intercostal nerve. And there are so many causes of the intercostal neuralgia. Most common cause is the trauma or the injury. So when the accidental injury is there, most fractured part of the rib is the angle of the rib. So whenever there is a fracture at the angle of the rib, intercostal nerve is also likely to be cut or the damaged. Or it may be pressed by the 2 fragments of the intercostal nerve. Or if there is a tumor at the root of the intercostal nerve, this tumor may press the nerve. Then also there is a pain along the distribution of the intercostal. There is also intercostal neuralgia. So trauma and the tumor, it may press the intercostal nerve right at the exit point from the intervertebral foramen from the spinal cord. So whenever a patient comes, there is a shooting pain, or is also called the root pain. So patient says that I got the pain starting from the backside and this pain comes anteriorly. So it means it is he is or she is describing the intercostal neuralgia. The intercostal neuralgia may be due to trauma, may be the tumor, or it may be due to the viral infection that is called the herpes. So herpes zoster infection is also in the rainy days. This viral infection is there, and the virus travels along the intercostal nerve and it goes along the cutaneous or sensory branches, and this virus, it reaches the skin, and to the skin it reaches to the cutaneous branches, and patient comes with a swelling or the crops of the blister formation along with the skin. So there is a blister-like swelling of the skin along the distribution of the intercostal nerve. So these blisters, they are solid and they are semi-solid, and they are filled with the viral material. And when there is a crops of these vesicles are present along the intercostal nerve, so this is a diagnostic sign of the herpes infection of the skin. So in this case also, the intercostal nerve is irritated because these viruses, they travel along the myelin sheath or the covering of the intercostal nerve, which undergo neuritis, and this neuritis lead to the intercostal neuralgia. So very intense pain is there in the cases of the viral or the herpetic neuralgia. So these are the few of the most common causes of the intercostal neuralgia. Now regarding the treatment of intercostal neuralgia, first we will give the medical treatment. The painkillers, they are applied, or some soothing calamine lotion over the skin to minimize the irritating of the skin may be applied. If the pain is not relieved by the strong painkillers, then the second option is that we inject the absolute injection alcohol. So absolute alcohol injections, they are injected right from the skin. We give the injection into the root of the intercostal nerve. So absolute alcohol injections are given in the root, so they may relieve the temporary relief of the intercostal neuralgia. But if it doesn't help, then the last choice is the intercostal nerve. This was the alcohol injection, this was the intercostal nerve block. So we block the conduction of the conduction due to the injection. Other is the intercostal neurectomy. In the intercostal neurectomy, what we do, we surgically cut the intercostal nerve at the root. So this cutting of the nerve lead to the relief of the permanent relief of the pain of the intercostal. So these are the intercostal neuralgia start. Second applied anatomy of the intercostal nerve is the pleural effusion. So in the case of the pleural effusion, when there is a collection of the fluid is there between the lungs and the visceral pleura and the parietal pleura. So the fluid is there in the parietal cavity, pleural cavity, in order to relieve the dyspnea. Because of this fluid, there is an external pressure on the lung, and the lung doesn't expand during inspiration and the expiration. So in order to relieve the lung expansion, we withdraw the fluid from the pleural cavity by putting a syringe in it, and we withdraw the fluid outside to relieve the dyspnea. So this position is called the removal of the pleural effusion. So a precaution has to be taken while withdrawing the pleural fluid from the intercostal space, that, as we know the anatomy of the intercostal space, that there is a space between the two adjacent ribs, and there lies the muscles, the external intercostal, internal, and all other muscles are present there. And this needle, this tip of the needle of the syringe should be not in the lower border of the rib, but it should be on the upper border of the rib. Because if we put the needle here, this is wrong. Why? Because we know in the costal groove, the lowermost position of the content is the intercostal nerve. As you know, there is a vein relation. So intercostal vein is run in the upper part, then comes the intercostal artery, and the lowermost is the intercostal nerve. That is the vein relationship in the body. So if we draw the fluid and we put the syringe in the lower part of the intercostal rib, then we may touch the intercostal nerve, and patient will get the pain. Intense pain will be there. So syringe should always be introduced in the upper border of the rib, because in the upper part there is no nerve is here. So there will be no pain with withdrawing the pleural fluid from it. So that is the second applied importance. Another applied importance of the intercostal nerve is the intercostal brachial neuralgia. intercostobrachial neuralgia is related to the second intercostal nerve. As we know, this lateral branch of the second intercostal nerve, lateral cutaneous branch of the second intercostal nerve, it runs in the axilla. So in some of the cases, as the second intercostal nerve traverses the costal groove, one of its lateral branch goes into the axilla. And in the axilla, it passes through the central part of the axilla, where lies the central group of the lymph nodes. And if this lateral branch of the second intercostal nerve, while passing through the axillary lymph node, which are central group, if they are enlarged due to some disease, then this nerve will be pressed. So this lateral branch of the second intercostal nerve is called the intercostobrachial nerve. Its name is intercostobrachial nerve. That is D2 branch. So in the disease of the lymph nodes they get enlarged, and these enlarged lymph nodes, they will press the lateral branch of the intercostobrachial nerve, and patient come with the intense pain or neuralgia in the axilla. So that is another applied importance of the intercostal nerve. Then comes the empyema necessitans. In the empyema necessitans, what happens? There is a bone TB or bone tuberculosis of the bones of the thoracic vertebra, which are very common in the lower thoracic and the upper lumbar vertebra. So whenever a cold abscess is there, and the cold abscess is there in the body of the vertebra, so whole of the bone marrow of the body of the thoracic vertebra, most common in the lower thoracic, what happens? That the bone marrow is replaced by the cold abscess. The cold abscess of the tuberculosis. And the wall of the thoracic vertebral body becomes very, very thin. As the T bacilli, they eat up everything. And because of this, what happens? This cold abscess may break through the vertebral body of the thoracic vertebra, and this pus or cold abscess, it travels in the intervertebral foramen along with the spinal T1 to T12 nerve any. So they accompany the intercostal branch, intercostal nerve, and this cold abscess may travel along with the dorsal branch, and this pus reaches the skin along with the cutaneous branches of the dorsal branch, or it may travel through the lateral branch and reaches with the branches they reach the skin, and the skin is having a swelling over where this cold abscess comes. So this cold abscess may travel along any of the cutaneous branch, and through this they reach near the skin, and the patient comes with the swelling of the skin due to the underlying collection of the pus which has traveled from the body of the thoracic vertebra, and they are appearing on the skin as the cold abscess swelling. So this condition is called the empyema necessitans, where there is a pus distribution along the sensory or the cutaneous branches of the intercostal nerve. So this is how we study the intercostal nerve along with its applied importance. That's the thing.